our needs or not. So believe me, friends, it's not a very simple task. This also is a scientific area, and we have to read between the lines to get the full essence of the manuscript. And we have exactly to know how to read the article purposefully, effectively, and systematically. Therefore, my dear friends and colleagues, I invite and welcome a stalwart of this field, respected Dr. Kishore Kabra sir, to provide an answer to this seemingly simple question, but yet not so simple task. So although Kabra sir does not require an introduction, but still Kabra sir is an eminent scholar and a neonatologist par excellence. Now, after completing his MD and DNB, sir has finished his DM neonatology. Sir is a fellow of multiple reputed scientific bodies like American Academy of Pediatrics, like fellowship in neonatal parental medicine at McMaster University. He's also done in fellowship in RNS Hospital, Sydney, Australia. Not only that, sir has also got a keen interest in the epidemiology and statistics, and he has done the same MSc in clinical epidemiology from Canada. Sir is currently the director of the NICU of Surya Hospital, Mumbai. He has more than 100 research publications in various index journals, and all has got multiple citations, and he has also delivered more than 300 guest lectures. He is also a reviewer for the Cochrane Neonatal Group, and he has been a chairperson for IEP Neonatology chapter from 2 years, 19 and 20. He's been organizing secretary of many conferences, including IEP Neocon in 2015. Sir has got an area of interest in critical care for the neonates in multiple statistical tests. Like, he has special interest in doing RCTs, and has also a keen acumen for teaching health research methodology. So with this, I welcome you, respected Kabra sir, and invite you to deliberate on this topic of how to reading a scientific paper. Kabra sir.
Good evening, Akash and Shashi. Am I audible?
Yes, sir, you're audible, sir.
And slides are clearly visible?
Yes, sir, they are visible, but kindly make it full screen, sir. So the icon near the 50th percentile at the bottom right.
Okay.
The third icon. The third icon, sir. Before 100%, there are three icons. At the bottom right, sir. Before 100%, the last icon of the three icons which are there. Yes, sir.
Okay. So, can I start?
Still, it is not there, sir.
So I think it's to do with the.
So you can first minimize it, then press the icon again, sir. Or you can reshare again, sir. So you can close the PPT and share again, sir.
Yeah. Is it working this time?
Perfect, sir.
So good evening. Thank you for very kind introduction. The critical appraisal of a manuscript is very close to my heart, and also the research methods. Now, when you become a doctor in the current era, we all need to know more about evidence-based medicine, and especially post-1990s, evidence-based medicine has become the buzzword. So as a physician, we need to have various skills to become a medical experts, like communicator, collaborator, healthcare advocate, taking leadership role, talking to community, and you also need to be a scholar. So when we deal with all these things, the one additional things one needs to have as a physician is appraising the literature critically, because it is going to be used in day-to-day practice. Now, once we learn this critical appraisal. It will help you to write your own paper, your thesis. It will help you to read others' paper. If suppose some article comes for review, then you would be able to deal with it better and more systematically. And you would be able to give a good critique, constructive criticism to improve the quality of the paper. Now, we all know that every year there are many publications and the growth of this is exponential. So one of the very humorous article and a book written by Dr. Oscar London from Berkeley, California, where his book is titled as Kill as Few Patients as Possible. He has written 57 chapters. And one of the chapters talks about you need to review the world literature fortnightly to keep yourself updated in your own field. Now, every year, his estimate was that there are about 2 million, 20 lakh articles get published in biomedical journal, and about 500,000, 5 lakh article in Medline. And then if you look daily, what is happening, it's about 1,500 articles in Medline, and maybe in current era, they are something like 2,500 per day. And about 100 trials get published every day from various disciplines. Now, if you are a keen researcher, to keep updated yourself, it's just going to be extremely impossible. So we have limited time. We are busy with our clinical practice, family commitments, socializing. So we have a limited time and research methods and statistics. And I remember as a MD student and DM student, whenever the research part will come to statistics and methods, we would get really scared. And it can be an intimidating science, but over the years, after acquiring knowledge and practicing, you know that just like you learn any other things, you can also learn methodology and statistics without any pain. We have to have a basic understandings. We don't need to be a strong methodologist or a statistician. And once you have a basic understandings, for finer points, you can always go to expert. So evidence-based medicine was the term coined in a group from McMaster, where they talked about 3 components: consensus, explicit, and judicious. So just like, taking this just very carefully about every aspect so that you are not making any mistake. Explicit meaning everything described very clearly, so it's reproducible. There is nothing in the dark, everything is black and white. And judicious, just like judges give their verdict, they deliberate every single aspect. So consensus, explicit, and judicious use of current best evidence in making decisions about care of individual patients. Now, we have somehow misunderstood that evidence-based medicine is only the evidence. Actually, if you look very carefully, evidence-based medicine is culmination of 3 things. One is best external evidence, then your individual clinical expertise, and patients' values and expectations. And when we combine these 3 things together, integrating, that is what evidence-based medicine is. Here is the pyramid of studies according to hierarchy. And you start from background information, then you go to case control studies, cohort studies, RCTs, critical appraised topics, and synthesized topics, and systematic review. And as the quality of evidence goes up, you know that the validity or the truthness or the strength of inference is going to be higher when you go to the systematic review, because this is very filtered information and somebody has already worked for you. Whereas these are the unfiltered information. And when you go from bottom to top, you are going to spend less time absorbing the gist of the topic. Now, I would strongly encourage all of you to visit this Equator Network website. And it is a quite comprehensive website, which gives you how do you report the studies and guidelines. And every month or 2 months, you go to the website, you would find that there are number of guidelines which are going up. Like last year, they were like 450, now it is 488. So it talks about how do you report the RCTs, like consort statement, and then depending on how the RCTs are changing, its extension. Then observational studies, drop statement, systematic reviews, PRISMA statement, so on and so forth. And this helps you in writing your own paper. This helps you in critiquing the paper. This helps you in reviewing the paper, and this helps you in helping your friend to write their paper better. So any manuscript, when you look at, so just quickly have a look. Does it have all this, a good title that encompasses what perhaps is going to answer, abstract in the standard format, and keywords? So once you see this and it looks exciting, then next thing you look at is the main text in IMRAD format, introduction, methods, results, and discussion format. And in the end, you'll find that there are concluding remarks and references and disclosures. So a manuscript should have this kind of structure. So when you look at the manuscript, a good manuscript should have all of these things perfectly aligned with each other. Then when you look at the introduction, whether it is your thesis or whether it is someone else's paper, or whether it has come for you to review. So in the introduction, typically you should see three components. You would have a topic which is being introduced as a general, and then it going to the specific aspect. And then it is telling you what is known about that and what is not known, what is unknown. And from this unknown, there comes the research question to answer that unknown. And there would be a hypothesis and a question put in a Picot format. Now, this Picot format, there are various ways people, and the science of this question is also evolved. Albert Einstein once said that if I had an hour to solve a problem, I would spend 55 minutes thinking about the problem and only 5 minutes thinking about the solution. So question is the most important aspect of any study, whether you are planning or critiquing and seeing what is actually being planned to be answered with that question. So most important thing. Then we were very familiar with PICO, but there are some extension to it. And P stands for population, patient, or a problem. What specific population of the patient you are interested in? So whether it is a newborn or preterm newborn or a low birth weight baby or baby with chronic lung disease, so your population. Then the intervention or exposure or prognostic factor, depending on the study design. So if it is the RCT kind of situation, then intervention. If it is a cohort kind of situation, then you would think about exposure to that factor. So what is your investigational intervention, exposure or prognostic factor under consideration? Then C is for comparison or control. What is the main alternative to compare with the intervention? And then the outcome, what are you trying to accomplish? What are you trying to measure? What are you trying to improve? What are you trying to see getting affected? And this outcome, you should have one primary outcome and then multiple secondary outcomes and additional things. But most important thing is what is the primary thing that you are looking at? Say, for example, when you are looking at trial of endomethacin prophylaxis, where they looked at use of prophylactic endomethacin, their primary outcome was not duct closure rate. Their primary outcome was neurosensory impairment at 1.5 years of age. So that way you look at specifically what the outcomes are. Now this PICOIDs got extended into PICOTs. So T is for time frame. What is the appropriate follow-up time to assess the outcome? Like, it is immediate, or whether it is 6 months or 1 year, 1.5 years, depending on your question. And then E is for effect size. What is the hypothesized difference between the 2 study groups or 3 study groups, 10%, 20%, 30% difference. And then S is for study design, whether it is a systematic review or RCT or cohort study or case control study or other type of study. And sometimes this study design is also given by T being type of study design. So, and the last one is type of question. Is it about therapy? Is it about diagnosis, harm, prognosis, prevention, and other? So you should be familiar with PICOT and then now the extensions of these PICOTs. So once you look at these PICOTs, classically, like, whenever you are looking at the question and its component, these are some of the examples. Say in newborns with hypotension, does treatment with adrenaline, it's a new drug under consideration, compared to dopamine, decreases neonatal morbidity and mortality. And you can add the other components of PICOTs like effect size and the time frame also. In children with Kawasaki disease, does treatment with IVIG compared to placebo decreases mortality? In postmenopausal women, does hormone replacement therapy compared to no hormone replacement therapy increases the risk of breast cancer? So whichever question you are trying to answer, try and put into PICOT's format. And your question should fulfill certain things, what you call as FINER. And this FINER is basically acronym whether this is feasible, whether you would have adequate number of subjects, adequate technical expertise, affordable in time and money, and is manageable in the scope. Interesting. Getting the answer. So your colleagues should also get excited if I am trying to answer something, and the community should also get excited. Otherwise, you would say that, like, it's not interesting. Then the next one is novel, whether it's something new that confirms or refutes or extends the previous findings. And then the important aspect is ethical clearance. It should be amenable to study that institutional review board will approve, and it has to be relevant to the scientific knowledge, to clinical and health policy, and for the future research. So remember PICOT, and your PICOT has to be FINER. Now, once you have gone through the introduction part and the question, and this PICOT should be clearly mentioned in your last paragraph of introduction, then come to the methods part. Is this study design suited to fulfill the aims of the study? So is this study appropriate for the question that is being answered? So ideal study design would depend on what is the purpose of the study. So if you want to estimate the prevalence of certain thing, then cross-sectional straightway, one point of time, how many patients that you are seeing in OPD today are anemic. So you're just doing 1 point estimate that gives you the prevalence. If you are interested in determining the natural history, then you need to follow them for certain period of time. So it's a cohort. If you are interested in causes or risk factors or people who are at high risk, you can do all of them. But typically, like, cost wise, you may be looking at, depending on the time frame you have, either of the cohort, case control, cross-sectional, or randomized trial. But when it comes to prevention of the disease or treatment, okay, when it comes to prevention or treatment of the disease, RCTs are considered gold standard. So RCT, case control, diagnostic test, cohort, quasi-randomized, before, after, survey, case series, it's a big conundrum. So how does one get around this systematically? So first question one should ask is, each investigator is the one who decides who gets what. So if investigator is assigning the exposure, if the answer is yes, then it is an experiment because the investigator has control on who gets what. If that's not the case, then it is like observational study. Remember, if you just gone to a movie theater and you are just observing the whole movie, you are just an observer. Everything has been already pre-planned by someone else. It's already recorded. So that is basically an observational study. Then if it's an experimental study, if the assignment is done randomly, so that everybody has an equal chance of getting into either arm of the study, then it is randomized trial. If not, then it is a not randomized trial. If it is an observational study, and if there is a comparison group, then it is an analytical study. And if it's no comparison group, then it is a descriptive study. You are just describing a cohort of low birth weight and their outcomes. But when you are comparing them with normal birth weight, it becomes analytic study. So observational analytic study depends what kind of direction you are going. You are going from exposure to outcome, smoker to cancer, then it is a cohort. You are going from outcome to exposure. So you are looking at who has cancer, then asking history and going back in their history. So you are going from outcome to exposure. Then outcome is already occurred here. It's a case control study. If exposure and outcome are happening at the same time, then it is a cross-sectional study. So cohort study, sometimes there is confusion. let's say today it's 5th March, and today you take a people who are smoking and not smoking, and looking at their exposure, and then found out who develops cancer or no cancer. And suppose you don't have time, then you go back to your hospital employment database 10 years ago, and from that look forward and see who has cancer today or not. So this is a prospective cohort. Okay, so you are looking at exposure and the outcome is happening in the future. Whereas in retrospective cohort, exposure and outcome are already happened, outcome is already happened, but the direction that you are looking, is starting with the exposure and then going at the outcome. Okay, if you go from outcome to exposure in reverse direction, it becomes case control study. So when you look at the paper, so case studies typically are cheap and easy to do. There is no analysis, and a lot of time it is whatever you got, you are describing. So bias reporting. Cross-sectional study are good for prevalence, hypothesis generation, but the cause-effect temporal relationship cannot be proved in that because of the short period of time you are observing. In case control studies, they are quick, cheap, and sometimes also called dirty. For rare, they are good for rare diseases because of the nature. And you can look at multiple risk factors. There is always going to be a recall bias and selection bias. Cohort studies start with cause, and then you look at the effect relationship, and they are good for rare risk factors, and multiple outcomes can be looked at one time, but they can be time consuming and costly. And experimental study are good for causality, prevention and therapy. They're expensive to perform. Sometimes you have to look at the ethical aspects also and clearance also, and they are difficult to do. So in summary, as a clinician, all of us need to be familiar with experimental randomized trial, cohort studies, which are prospective, but as I told, sometimes the cohort studies can be done in a retrospective manner, although they are done very rarely, mostly they are done in a prospective manner. And then case control studies, retrospective. So if you are familiar with tree design, 90% of the time you don't need to think more than the basic fundamentals of these three designs. Now, for every question about therapy and prevention, can you always do a RCT? Take an example. If my research question is, does use of parachute reduces the risk of death in healthy adults jumping from a plane? Who is going to participate in my study? Which ethics committee is going to give me the permission? Okay, take another example. Does exclusive breastfeeding in first 6 months of life improve IQ in the healthy infants? So which ethical committee is going to give me clearance for something like that? So always remember that although for therapy and prevention, RCT is gold standard, sometimes it may not be possible to do RCT in these situations for various reasons. And some of the glaring examples, although little exaggerated, I have portrayed so that you understand the concept. Now, when you are looking at the methods, apart from this, we need to look at whether the study is confirmatory in nature, it is exploratory in nature, or it is just descriptive in nature. That should be very clearly seen in the methods part. And the type of study that was chosen, does it permit the question that they want to answer, the aims and objectives, would they be able to fulfill? And every aspect of PICOTS, the population, the intervention, the comparator, various outcomes very clearly defined, the time frame, effect size, and the type of study seat, it should be explicitly defined, the period of the study, ethical clearances. So all this should come very, very clearly in the method section. Now, when you look at this methods, you also have to look very carefully, especially in randomized trial, how the groups in the intervention and control are flowing through the study, how the patients are selected, how they are given the treatment, and if there are any losses to follow up, how much losses are follow up, and whether there is any bias introduced there, and how the outcomes are measured. So selection, performance, exclusion, and detection, you can short form this as SPED, SPADE. And we'll see what is this. So bias is nothing but systematic deviation from truth. So if you are having incomplete randomization, then the selection bias is introduced. If you are treating two groups differently, one group being treated with good nursing staff, good team of doctors, given additional intervention, provided more care, then you are introducing the bias. Then suppose somebody's lost to follow-up has not done well and he's been withdrawn from the trial unfairly. Then it is basically you are introduced to exclusion bias. And the outcome one who is measuring, whether he's blinded or not. So whether your outcome is something like death, then there is no cheating. But if your outcome is something like a PDA size or IVH, no IVH, we all know that, like, whenever we were in residency, we look at the chest X-ray and you don't see anything. And then you do a CT scan and you see a primary complex. And then once that CT scan report comes, you put X-ray and then you start looking at X-ray and you start to see primary complex. So sometimes if you are having a prior knowledge and you are the judicial assessor of the outcome, you can get biased. That's why the people who are assessing the outcome should not be aware of the group assignment. It's extremely important that through this process, we need to know how the subjects are entering the study, what kind of interventions they are getting, co-intervention they are getting, and how the outcomes are measured. And although the bias itself, like, there are 350 different types of biases, but these are the most important biases that come in play. And when you look at paper, look at each of these steps, whether these biases are introduced. Now, generally we say single blind, double blind, triple blind studies. And generally it's assumed that single blind means it's the participants who are blinded. And double blind means it's participants and the caregivers or assessor of the outcome. Triple blind meaning participants, healthcare providers, and those who are assessing the outcomes. But there is a confusion always, like, which one group, which two group, which three group are blinded. Suppose you are doing a very large study and multiple people are involved in the whole process. So the blinding can happen at 7 different levels. So whenever you are doing a RCT or a cohort study, you should try to blind as much as possible whenever it's possible, like participants blinding. Those who are providing the care, they should be blinded. Those who are collecting the data should be blinded. Those who are assessing the outcome, like say, for example, outcome is PDA closure. So those who are doing echo, or outcome is IVH, those who are doing sonography, or the lab people. So those should be blinded. Then you just code data as A and B without telling what is A and what is B. So data analyst should be blinded. Similarly, data safety monitoring committee, if it is a large study and you are planning interim analysis, and then write the manuscript in a blinded manner, like assuming A and B as 2 different things. And then once the blinding is unblinded, then accepting the manuscript. So you can go to extreme. So blinding can happen at 7 different levels. Now, in methods, you look at the statistical part. So what kind of baseline and outcome variables are under consideration? Are they categorical outcome? Are they ordinal outcomes? Are they ranked outcomes? Or they are on a continuous scales? Because on this basis, your test will be decided. And if you are choosing the appropriate statistical test, and also a description about power and sample size. And all of us who actually do the studies for research purpose for students realize that a lot of times the sample size that you want to have for the study may not be enough in 2 years, 3 years, 1 year's time. You are doing the fellowship or DNB program, and then you try to adjust it in such a way that, like, you have hypothesized a higher effect size, higher difference between the 2 study groups. So when you read the paper and try and see whether it is reasonable, whether the difference they are hypothesizing is biologically plausible, and whether the similar kind of things are observed, and what are their assumptions based on. So your statistical tests, although it is a altogether separate talk, but in nutshell, if you are having 2 different groups and if your outcome are yes, no, categorical or proportions, you would use chi-square test or Fisher exact test. If you are having numbers on a continuous scale, like blood pressure, blood sugar, birth weight, gestational age, then you'll use two different groups, unpaired t-test. If it is ranked or ordinal data, or your measured quantity is not normally distributed, you'll use Van Whitney U test, and time to event, Mantel Haenszel chi-square test. So when you look at the statistical methods in the paper, see that these things are described there. So if it is two related groups for proportions, McNemar chi-square test. If it is continuous on a continuous scale, numerical continuous or numerical discrete, pair t-test. If it is rank or ordinal data or not normally distributed continuous data on the continuous scale, you'll use Wilcoxon sign rank test. And if it's more than two groups, then the extension of the test can be applied. I would share whole presentation with Akash, and he would forward it to you. So don't bother too much about it, but have this table handy so that whenever you are looking at the paper, you can check whether the appropriate statistical tests have been applied in the manuscript or not. Now coming to the results, most important part, they should, whether they are clearly written or not. And they should be written objectively without interpretation, without writing what these results mean. So don't write anything more than results in the results section. Don't start discussing paper there. If you see something like this in happen, it's annoying. And this should be relevant, addressed directly to the aims of the study. It should be well structured and readily understandable. So all of you who read paper, you understand that basically there is a table, various tables. So table 1 we typically of a baseline characteristics. Table 2 would be of any short-term outcomes. Table 3 will be like long-term outcomes. This can change, but typically depending on how much the individual journal will allow, this is how the tables will flow. And if it is a RCT, you would also like to see a consort flow diagram, flow of the participants and additional analysis. Don't try to duplicate the information that is there in the table into the figure and figure into the table. They should convey two different things so that there is no redundancy. You are not repeating the same information from table into the figure. Coming to the discussion, you start discussion with the overall interpretation of your results, then talk about your strengths of the study, limitations of the study, addressing sources of bias and imprecision, and if relevant, multiple analysis are done, then how the p-values have been adjusted or not. And then comes if the study methodology is good, there are no biases, that means the study is internally valid. Okay, there are no threat to the results of the study. Then you would say whether the results of this study, internally valid study, can be applied externally, whether it can be generalizable. Some studies done in Lucknow, can that similar kind of study population, if I have, can it be applied to people in Mumbai? And the interpretation should be consistent with the results, balancing benefits and harms, and considering other relevant evidence. And here you will talk about the implications of your results in terms of implications for day-to-day care, patient care, and also implications for future research. So if your study is a large study and shown that something is beneficial, then you would say that it can be used in similar population. And if suppose it's not answered, then you would say that results of this study should be replicated in more studies like that. Towards the end of the manuscript, you like to look at conclusions, and they should be appropriate to your results. Also talk about the registration with clinical trial registries, or if it is a systematic review, Prospero, so on and so forth, and whether the protocol was written and it's available, and who is funding the study, whether there is any conflict of interest, and the references should be updated according to the requirements, whether they are there. Suppose you are asked to write only 10 references, and if you put 20 references, that also becomes a problem. Now coming to a very, very interesting and important concept. A lot of times when we talk little loosely, saying clinically significant. So there is a concept called statistical significance, and another is clinically significant. But post 1990s, people have stopped using the word clinical significance. They call it clinically important. So statistical significance and clinically important. Take this example where you have study A, where there are 10 subjects enrolled in each group, and you are looking at the weight loss program. Group A loses 20 pounds from baseline, and group B loses 3 pounds. So the overall difference is 17 pounds, but the p-value that you get is 0.07. So the clinically important difference is there. Difference is 17 pounds between these two, but the p-value is not significant. So you would say that this result is clinically important, but statistically not significant. And this may be because your study was underpowered and you enrolled fewer subjects. Now, suppose you enroll 1,000 subjects in each group. The weight loss in group A is 5 pounds. Weight loss in group B is 3 pounds. And the difference overall between 5 and 3 is 2 pounds. Because you have such a large sample size, your p-values come at 0.03. So whether from 100 kilo you lose 2 pounds, whether it is meaningful or not, clinically depends. So it is a judgment, and you cannot say that this much difference is significant or this much difference is important or not. It is your clinical judgment. Here, the statistical significance is there, but you would say that, well, 5 pounds and 3 pounds, 2 pound difference only, it's clinically not important. So whenever you look at the study results, there are two possibilities. If the study results are come significant, you have to see whether the clinically important difference is found. So if the results are statistically significant and clinically important, then you are saying that the results are convincing to change the practice as shown in the manuscript. If your results are statistically significant, p-value is less than 0.05, but they are clinically not important, just like the previous example I gave you in the previous slide, you would say that there is a real effect, but it's small, and really whether I should change my practice is a question mark. Or I would have a strong feeling, then I can replicate the study, and if the results come like this, I would accept. If they don't, then I would say that it's not meaningful. If your p-value comes greater than or equal to 0.05, 0.05 exact value is borderline significance. So you would say that the result is statistically not significant and clinically important. And you would say that we need more evidence. Your study was underpowered. So you would have more subjects, study with more subjects, adequately powered. And you would perhaps from here, you would go here, and that may change your practice. Sometimes you would find result is statistically not significant and there is no important difference also. That means that we don't need to change the practice if the study has got adequate number of subjects. So don't confuse yourself with statistical significance and clinical significance. Start using the word clinically important and statistically significant to avoid the confusion. Now, very first time in 1990s, the McMaster group came out with guidelines for how to read a paper, how to criticize the manuscript. And these are called JAMA guidelines. And take an example of therapy and prevention. So you are typically looking at RCT situation for treating some disease or preventing some disease. So one would always ask 3 questions, and only if the first question's answers are reasonable, satisfactory, then you will proceed to the next question. So first was, are the results of the study valid? If the results are valid in primary and secondary question, then only you will move to what are the results. And if the results are shown difference, then you would ask question, will the results help in caring my patients? So 3 questions. What are the results of the study? Are the results of study valid? What were the results, and will the results help in caring my patients? So when you come to the are the results of the study valid, there are primary guides and secondary guides. Primary guide, was the assignment of patients randomized? If it's randomized, the answer is yes. Then you'll ask, were all patients who entered the trial properly accounted for and attributed at its conclusion? So was the follow-up complete? Were the patients analyzed in the groups which they were randomized? So this is basically intention to treat analysis. If they are treated differently, and then you exclude those who are treated differently and only followed protocol, so then it is called per protocol analysis. So one should be familiar with what is intention to treat and what is per protocol analysis. So intention to treat is more like real world situation where sometimes you go in the round and say start this baby on that protocol and actually it does not get started. Okay, so that kind of situation, real world. And per protocol meaning actually you've gone to the round and you said you start that protocol and it's actually done. So that is like per protocol analysis. Take example of trial of endomethacin prophylaxis, and in which suppose group which was supposed to get endomethacin accidentally gets placebo. That subject, even if it got placebo, would be analyzed as if it's received endomethacin. In the other group where placebo was supposed to be given, accidentally endomethacin is given, that subject will be still analyzed as if it's received placebo. This is intention to treat analysis. What was your intention when you actually randomize them? Irrespective whether you get the desired intervention or do not get the intervention or only get half of the intervention, you will be analyzed as per your randomization group. So once the answer to primary guides are satisfactory, then you will ask were the patients, healthcare workers, and study personnel blinded to the treatment? Were the groups similar at the start of the trial? And aside from experimental intervention, were the groups treated equally or there is a partiality and there was a performance bias, like, a particular group got more favors, more better treatment. Once you are satisfied with your primary and secondary guides for the first question, then you would see what are the results, how large was the treatment effect, how much was the difference, 1%, 2%, 10% favorable. And also only don't look at one number, but also look at its confidence interval, best case scenario and worst case scenario, 95 of the 100 times, what would be the confidence interval. And if suppose the effect size is good and confidence intervals are narrow, then you would ask question, will these results help in caring my patients? Are my patients similar to that in the study? Whether all clinically important outcomes are considered or side effects and long-term outcomes are not described? And are these treatment benefits worth the potential harms and costs? So this is how these JAMA guidelines were used. And then came this 1996 and subsequent revision 2010 consult guidelines for RCTs. So it's consolidated standards of reporting of trial, typically look at 25 items. I am not going to get into the details, but how the title abstract has the word randomized, how the introduction should be. In methods, there are 3 to 12 items. From results, there are 13 to 19, and discussion 20 to 22, and others 23 to 25. So this is a good way to look at when you look at the RCT, you are writing your own or reviewing someone else, whether all these items are covered as in the checklist. You'll also look at the consort flow diagram, how the subjects are enrolled in the study, how the randomization is happened and how they are allocated to the treatment, how long they have been followed up and is it as per the protocol, and how many are actually analyzed. So this becomes an important figure in a manuscript. Now lately people have started from the JAMA guidelines, this critical appraisal skills program, they have modified the checklists and made it more modern. And these are called CASP tool, critical appraisal skills program tool. And they are different for RCTs and cohort studies. So you can just go to the website and download these things and use in practice. Irrespective, more or less the theme remains the same, whether you use JAMA or whether you look at the consort or whether you look at the CASP. You need to be more and more people are now using CASP because they have become more concise and precise. If you are more interested in reading further and enhance your skill, you can look at these 2 books. PDFs are also available on the internet. You don't have to necessarily buy them. How to read a paper and User's Guide for Medical Literature. Now, when you look at any paper, you know that positive results are likely to be published and negative results are not likely to be published. And sometimes, the results trials are altered. So we have to be honest and say that a successful clinical trial is the one that reaches the correct conclusion and not the one that produces positive result. So even if your study that you are looking at has given negative result but has answered something very clearly that this therapy does not work, then have trust and faith if the study is done properly. Now the next part, I'm just going to zoom through some of the things. This was one of the systematic review that my colleague Hari and we did together. And this is umbilical cord milking in preterm infant systematic review and meta-analysis. So forest plot reading has become an important part of systematic review. It is called forest plot because it's a forest of lines, 1, 2, 3, 4, so on and so forth. It is forest lines. Richard Pito, famous statistician from UK, jokingly said, he was a breast cancer researcher with the name of Forest, and he jokingly said, well, we are labeled this forest plot in honor of him, but actually the history is that forest plot is basically lines. There are lines of forest of lines, and that's why it's called forest plot. Now, when you look at forest plot, start reading systematically one by one and don't get intimidated by whatever you are seeing. So first is like, you are looking at intraventricular hemorrhage. That is your outcome of interest. Then you look at the various studies. They can be arranged alphabetically, or they can be arranged year-wise, or they can be arranged depending on the weight assigned to the study. Then here is your intervention group, umbilical cord milking, and it gives you events to the total number of subjects that are randomized. Here is your comparator group or a control group, events and total number of subjects, and this weight assigned to the study. So the weight assigned to the study depends on the number of subjects, number one, and number two, the number of events that are happening. So larger number of events are happening, then the study gets more weight. So number of subjects and number of events, and also the precision around this, confidence interval around this. Then it's the measure of association. It may be risk ratio, or sometimes what we call as relative risk or odds ratio or risk difference. So this will give you the point estimate and its confidence interval. Same information is depicted in this forest plot. That same information. This point is 0.49 here. And this is 0.14 going from here, 0.14 to 1.72. Then comes the pinnacle, the most important part of your forest plot. So here is your measure, whether it is risk ratio, odds ratio, risk difference, mean difference, weighted mean difference. If it is a ratio, then point of no difference or line of no difference will be drawn at 1. If it is a difference like risk difference or weighted mean difference or standardized mean difference, line of no difference will be drawn. Here it would be 0. Then these are individual studies. What you are seeing, these boxes, these are point estimate, and the size of the box will depend on what is the weight assigned to the study. For example, this study has a 60.9% weight. So total weight would be 100%, but of that 60.9% weight is given to this study. Then when you combine results of all these studies together, you get a diamond. Okay. So the center of the diamond is the point estimate, and the left hand and the right hand extremes are the 95% confidence intervals. So once you are at this, if your diamond is completely on the left hand side, then you would say that it favors the intervention. If it is completely on the other side, you will say it favors the control group. Once you are through this, then look at this part also. So total number of events, 75 out of 438 in the umbilical cord milking group, and 83 out of 452 in the delayed cord clamping group. Then it talks about heterogeneity. And if the p-value of less than 0.05, that means it's heterogeneous, and also look at the I-square value. And typically the old literature was that if it's 25%, 50%, 75%, small, medium, large. But the grade handbook now have revised these numbers to adjust for uncertainty, like less than 40% may be small, 30 to 60% may be moderate, 50 to 90% substantial, and 75 to 100% may be considerable. So there is a little overlap describing uncertainty. And then this final thing, test of overall effect. So if this Z value and P values are significant, like P 0.05, you would say that the results are significant without looking at this also. If you are crossing the line of no difference, this diamond is not crossing the line of no difference, that means your p-value is going to be more than 0.05. Here we were talking about IVH, any grade, then we look at severe IVH. Here 24 out of 356 subjects have got severe IVH, and here it is 12 out of 362. And you are finding that there is no heterogeneity, and the overall p-value is 0.05. You're looking at the confidence interval, point estimate is 1.95, going from 1.01 here, just crossing that, like, just above 1 and going to 3.76. So you are saying that babies who are small and they have done umbilical cord milking, then you are at the risk of having severe IVH, and you should not be practicing that in this group. Now coming to a little bit of just an introductory part about measures of association. Akash, do we have time or we need to wind up?
No, sir. Please continue.
Okay. So you can suggest any time if I have to stop. So measures of association, when you look at these studies, sometimes they give risk difference, number needed to treat, number needed to harm, relative risk or risk ratio, relative risk reduction, or odds ratio. And focus on, don't bother writing, but just try and understand concept. I will be sharing all the presentation, which Akash will forward it to you. So take an example of a RCT kind of situation, and you are looking at two groups, treatment group and control group, and event and no event. So who is developing disease and who is not developing disease in the treatment group and control group. Let us say that in the treatment group, you have A plus B subjects, A develop disease and B do not develop disease. In control group, you have C plus D subjects, C develop the disease and D do not develop the disease. Then how much is the risk in the treatment group? It is also called as experimental event rate, A divided by A plus B. Okay, A divided by A plus B. So that is absolute risk in the treatment group. What is the absolute risk in the control group? C divided by C plus D. When you look at any manuscript and they are given these things, you can calculate all these things by yourself if you understand this table. Then risk difference. It's also called as absolute risk difference, absolute risk reduction, risk difference, or event rate difference. Just like sometimes one of us may have more than one name, 8 names. So statistician also have given sorry, many different names to risk difference, like absolute risk reduction, absolute risk difference, event rate difference. And this is calculated by difference between the control group and experimental group. So CER minus EER. So this quantity minus this quantity. Now we lot of times see number needed to treat. Number needed to treat is nothing but 1 divided by risk difference. If it is a harmful thing and is negative, you will call number needed to harm. Take an example of whole body cooling trials, and you find that the rate of adverse outcome, death or impairment, it says 62% in the group which is control group and 47% in the treated group. So the difference between 62% and 47% is 15%. So 15% is 0.15. So 1 divided by 0.15 would be 6 point something, and you round it up to the number higher than that. So that is like 7. So from risk difference, you would say that in this example of hypothermia, if I treat 7 subjects with therapeutic hypothermia, I would be able to prevent 1 extra death or impairment. This word extra is also important because not everybody in the control group is having the bad outcome. So then is the relative risk, also called as risk ratio. It is the ratio of two things, experimental event rate and control event rate. So basically this quantity divided by this quantity. And then relative risk reduction is basically how much reduction is happening from the control group. So 1 minus RR is your relative risk reduction. And then one needs to be very careful what exactly the paper is giving. Doesn't matter whether they are giving any of these things. as long as you know what they are giving and how do you interpret them. Sometimes the paper will give you the odds ratio. Now, odds is basically event divided by no event. Okay, odds is event divided by no event. So odds of the disease in the experimental group is A divided by B, A divided by B. Whereas when you looked at the risk, it was A divided by A plus B, and as shown in the earlier slide. In the control group, it's C is the event and D is the no event. So C divided by D. And odds ratio is basically ratio of these two odds, this odds and this odds. And because, sorry, A by B divided by C by D, if we simplify it, it becomes AD by BC, and that's why it is called cross product ratio. You are multiplying these two cells and dividing by these two cells. Remember how odds ratio and relative risk are different from each other, and how is this formula. If your outcomes are very, very infrequent, very small number, then this odds ratio and relative risk will be close to each other. Take example, suppose there are 1,000 flights that take off from Mumbai airport every day, and one of them needs to be say stopped for various reasons. So the probability of stopping that flight is 1 divided by 1,000, whereas the odds of stopping that flight is 1 divided by 999. Take another example. Suppose you are putting your money in horse race. There are 4 horses which are running the race, and only one is going to be the winner. So the probability of winning is 1 divided by total number of horses 4, 1 in 4, or 0.25. If it is counted in terms of odds, then 1 horse is going to win, 3 are going to not win or lose. 1 by 3 is 0.33. So in this example of horse race, the probability of 0.25 is equal to odds of 0.33. Take this famous study, trial of endomethacin prophylaxis, just to give a solved example. In the prophylactic endomethacin group, there were 601 subjects. 142 developed PDA, 459 did not have PDA. In the placebo group, 301 developed PDA out of 601. So here it is looks like 25% approximately. Here it is like 50%. So experimental event rate is 142 divided by 601, that is 0.24. And here it is 301 divided by 601, that is 0.5. So the risk difference between these two, 0.50 minus 0.24 is 0.26. Number needed to treat calculated from this risk difference, 1 divided by 0.26, approximately 3.84, you round it to the 4. So you would say that if I treat 4 subjects with prophylactic endomethacin, I would prevent 1 symptomatic PDA. Then the relative risk, experimental event rate divided by control event rate, taking ratio of 0.24 to 0.50, that is 0.48. Relative risk reduction, 1 minus RR, 1 minus this quantity, that is 0.52. So you are saying that from this 50%, I am able to reduce it to 24% by using prophylactic endomethacin. So if you assume 50% as 100%, then 24% becomes 52% reduction. That is relative risk reduction. And then the odds ratio of these two odds, multiply this cell by this cell and divide by this, that is 0.308. See how these numbers are different. RR is 0.48, but the odds ratio is 0.308. So sometimes it is said that odds are more sensitive than the relative risk in this kind of situation. They would go further away from 1 if the number of subjects having the particular outcome are reasonably enough. Now coming to the diagnostic test situation, whether the target disease is there and target disease is not there, and diagnostic test is positive or negative. So if your diagnostic test is positive and target disease is there, you call it as true positive, represented by A. Target disease is not there, but your test has come positive, you call it as false positive, represented by B. if your test hits come negative, but the disease was there, so it's false negative, you missed that, represented by C, and the target disease is not there and disease is not there, that is true negative. So you want the test to have maximum number here and fewer number here and here. So this is basically total number of patients having disease. This is total who are healthy, and this is test positive and then test negative. So accuracy of a test is how accurately it's picking up true positive and true negative divided by everything. Prevalence of the disease is A by C divided by everything. And then comes the important properties of a diagnostic test like sensitivity. Sensitivity is also called as true positive rate, or in simple English, how often the test is coming positive, those with the disease. So A divided by A plus C. So it's in this table, it's a vertical property. True positive divided by true positive plus false negative. Specificity, how often, it's a true negative rate, how often the test is coming negative if you are healthy. So it is D divided by B plus D in this example. And then comes the positive predictive value. So just play of words. When you hear the word, question is asked, what is positive predictive value? Just put first letter second and second letter first. Say positive predictive value is nothing but predictive value of a positive test. Okay, predictive value of a positive test. So if the test is come positive, how often you have a disease? A divided by A plus B. And negative predictive value is if the test is come negative, how often you are healthy? So D divided by C plus D. Okay, D divided by C plus D. If the test is come negative, how often you are healthy? And then comes the likelihood ratios of a positive test and likelihood ratio of a negative test. They work something like odds. So the likelihood ratio of a positive test is in simple English, how often the test is coming positive among those with disease. So A divided by A plus C as compared to those without the disease. So A divided by A plus C and B divided by B plus D. How often the test is coming positive in those with disease as compared to those without disease. And likelihood ratio of a negative test is how often the test is coming negative among those with disease as compared to those without disease. So C divided by A plus C and divided by D divided by B plus D. These likelihood ratios, although look complicated, they are intuitively attractive to clinicians because likelihood ratio of 1, meaning whether you do a test or not, it is not changing your prior assumptions. Whereas if the likelihood ratios are going more than like 9, 10, then the diseases become more likely. Or if it's getting closer to 0, then the diseases become unlikely. Take this paper published in Indian Pediatrics in 2005, compared PCR with the blood culture, which is the gold standard for newborn sepsis. So 100 subjects. So true positives were 9, false positives were 4. So PCR positive total were 30, PCR negative were 87, 0 false negative and 87 true negative. So the sensitivity was 9 by 9, 100%. Specificity was 87 by 91, 95.6%. Positive predictive value, if the test has come positive, how often your disease is 69.2%. And negative predictive value is basically 100%. If your test is negative, that means you are healthy. And the likelihood ratios were basically, if the test is come positive, the likelihood is increased by 22.7, that is 23 times. And if the test is come negative, that means you are absolutely healthy. You do not have chance of having the disease. Okay, so with this, Akash, if you have time, I have 5, 6 quiz questions and anybody can randomly answer them.
Sure, sir.
So here is the question and anybody can answer one by one. Which is the ideal observational study design in following situation to estimate the prevalence of the disease?
Cross-sectional.
Very good. So ideal study design to determine the natural history of disease. Natural history of disease. Okay. Ideal experimental study design for prevention. Prevention of disease. So let us say that you are having vitamin K given to the, suppose the study was not there, and newborn babies get vitamin K in one group and other group gets placebo. What would be the ideal study design in such situation where you want to prevent hemorrhagic disease of newborn? Now nobody will allow you, but suppose you are doing it for first time. So we said that when it comes to prevention, the gold standard is randomized control trial. Treatment of the disease, ideal study design. Yes. Hello. Akash, can you hear me?
Yes, sir, you're audible.
Yeah. So when it comes to treatment and prevention, the gold standard is randomized control trial. And then last few slides, which is the ideal study design to study rare disease.
Case control.
Very good. Now, which statement you'd use for RCTs from these choices? Start, consort, quorum, stop, quadas.
Consort.
Consort.
Very good. For cohort study,
Strobe.
okay. Standard reporting items on observational studies. Okay. For case control studies, remember, like, cohort, you do opposite of cohort, ProHawk. Okay. So for case control study, also sometimes called as ProHawk study, which statement? Again, stand standard, but this would be strop for case control studies. For diagnostic test,
Start.
okay. For meta-analysis of RCTs,
The final criteria, and also you have explained in detail exactly what we have to look in the methodology section, research section, and discussion section, sir. So thank you so much once again on behalf of everyone. Now there are a few questions in the chat box, sir.
okay, I'll take one by one. Is it possible for us to know how should we choose briefly which article to read? So I think it depends on your purpose. Say, for example, you are taking rounds and you are dealing with newborn with hypertension, and there is a discussion going on with the consultant that, like, whether I should use dopamine or dobutamine or adrenaline. And then basically, like, you just quickly search the PubMed, find out the article. So basically it depends on the purpose. Now, suppose for that, if you already have a systematic review, which is recent one, like say last 1 year or 2 years, best is to invest time in that, reading that. And if it's not there, then go for RCTs. If you don't find RCTs, then go for cohort studies. If you don't find cohort studies, then you look in the evidence pyramid, whatever else you will find.
Yeah. Sir, is it possible to look from title and abstract also whether this study would be beneficial to us or not? Like briefly glancing through a simple, let's say sample testing or something like that.
Okay, I'll just basically, like, what you do is that in PubMed, simple, for example, in the search box, you put newborn hypertension treatment, some of the keywords. It would throw out maybe 10,000 articles. And then on the left-hand side, you can apply the filter. First, say meta-analysis, systematic review. And if you find the recent one, then perhaps that is what we would go with.
Yes.
And what you said is right. Like, once you identify, then going through title and abstract, you would know which one would be relevant to you.
Okay.
How to search paper or article online. So as a first thing, I think whatever question you have, try to put in Pico form and then put it in the PubMed, and you may find something straight away there. If you don't find anything, you can put that same thing in the Google search also, or Google Scholar, and then you may find there. If you have access to other databases through your institute like Embase, SinaHealth, psych info, depending on what kind of question you are asking. But mostly you will find in terms of like, newborn literature, if it is coming to treatment, prevention, diagnosis, most of the things in PubMed, Embase. And also, if you are very familiar, you can search Cochrane Library directly. Cochrane Library gives 4 things. It gives you systematic reviews, those which are completed, those which are in protocol stage. It also gives you RCTs, and sometimes there may be a specific question called critically appraised topic you would find, and it is easy to search, it's free. Just if you type Cochrane Library Google and go to the link and search, just like you search in PubMed, you would be able to find. So how to search paper online? Should we keep the equator checklist with us while reading a paper also, or only the sake of reviewing it? So all the checklists are good when you are writing your own protocol. They are also good when you are writing your own paper or critiquing the paper. I think you should, whenever you are doing journal clubs, you should start using them one by one so that you become familiar. If you are not using it in day-to-day practice, whatever you are learned, you would forget everything. I used to take classes for statistics, 13 classes at KM, 3 hours each. And then at the end of the session, everybody will say, you said a lot of good things. And then I'll ask them, what did you learn? They said, well, when you said it sounded all right and remembered, but then you forget everything. So unless and until you incorporate these things in day-to-day practice while you are taking rounds, while you are doing journal club, while you are looking after your patients, you are going to forget everything.
Yes, sir.
Okay, then how do we come to calculate sample size on our own? So there are these days apps available, but sample size, perhaps like, to start with, you should take help from your consultant. And once you are familiar, you can use, but generally it depends on what is you want to prove, what kind of outcome you are looking at. Suppose your outcome is dichotomous, yes, no kind of thing, binary. Then the sample size would be on the basis of that formula. If you are having 1 group or 2 group or 3 group, and then if your outcome is on a continuous scale, whether you are looking at correlation. So basically, depending on what is your primary outcome and how you are going to measure how many groups you have, what kind of alpha error, beta error, meaning the false positive, false negative, you are ready to accept. Putting these things, and once you are familiar, then it's pretty straightforward. If you do not have access to app, you can have various websites for sample size calculation these days. And like, if you are interested, you can write an email to you. I can share those resources with you. My email address is nskabra@gmail.com, and I can share the sample size websites or the softwares.
Thank you.
Is there a way to know that information and conclusion provided in particular paper is enough, or we have to see through the papers as well to reach a definitive conclusion? Very, very interesting question. Like you saw the tip paper results, and then like, I believe all of these people are from neonatology background, Akash?
Yes,
Or
the
no?
majority is.
Okay. So when this tip paper was presented prior to publication in the Pediatric Academic Society meeting, their outcome was not PDA closure rate. Their outcome was neurosensory impairment. So when they looked at the PDA closure rate, so first question was first interpretation was that, well, if you use prophylactic endomethacin, you would be able, you will be able to reduce the symptomatic PDA roughly by 50%. So those who are in placebo group, the PDA rate is 50%, and those who are received prophylactic endomethacin, the rate is about 24%. So that was one interpretation. Second interpretation was 50% in the placebo group did not develop PD, so they were not destined. So that means you have used this medicine unnecessarily in those 50%. The third interpretation was the risk of severe IVH was lower in the group which received prophylactic endomethacin. So you'd say, well, although like, prophylactic is not working in 50%, the 50% chance that you are not developing symptomatic PDA, but because you are using prophylactic endomethacin is going to reduce IVH, let's start using it prophylactically so that IVH rates are low. Then the most important thing is long-term outcome, 1.5 year outcome. Death or impairment, no difference. So then you are saying that, well, it reduces PDA, it reduces severe IVH, but actually it does not change the long-term outcome. So each of these things one needs to look carefully and deliberate. So don't accept whatever is written paper straightway as it is and look at each and every aspect. Okay, can you elaborate on effect size? How can you calculate it in our RCT? So let us say, take an example. Let's say that we are doing a study of paracetamol versus endomethacin in treatment of PDA. And from past experience, we know that the closure rate with endomethacin is say 70% or 80%, let's say 80%. And you are hypothesizing that by using paracetamol, the PDA rate, closure rate would be superior, like say 90%. This is your hypothesis on the basis of certain assumptions or prior studies. So 90% and 80%, the difference is 10%. This is precisely the effect size. How much is the difference between two? Suppose in one group, the bad or good thing that you are measuring is 50%, and in the other group, it is 25%. The effect size is going to be 50% minus 25% is 25%. Suppose the rate of mortality is 5% in one arm, and the other arm, the mortality rate is 2.5%. So the effect size here is 5% minus 2.5%, which is 2.5%. So this is effect size. How the weight is decided in the forest plot. So as I said, the weight of ascent to each study is dependent on three things. Number one, the number of subjects in the study. Number two, number of the events that are happening in the study. Suppose you have two equal studies with equal number of sample size, but the frequency of bad things that you are measuring happening is lower in one study, that study will get lower weight. And also the precision. So just like suppose you have two residents who are asked to report to work every day morning at 9 a.m. and resident A comes at 9 a.m. then next day 8:30 a.m. then next day 9:30 a.m. then he gets firing, then he comes at 8 a.m. So his time to report average is 9, but he's coming anywhere between 8:30 to 10 o'clock. Whereas there is another resident who reports at 8:59, 8:58, 9, 9:01. So his time to report is 9, but average 95 the 100 times he's coming between 8:57 to 9:03. So he's more precise. So you would trust him more, you would give him more responsibility. Similarly, when you look at these studies, the weight assigned to study which has got more precision gets naturally more weightage. Then RCT, cross-sectional RCT, consort. Okay. If diamond is just touching the line of no significance, do we conclude that results of this meta-analysis are clinically unimportant? It depends. It depends on, like you would say that like there is a trend. There is a trend in that direction. If it is touching, suppose relative risk is your measure, and if it is including that one towards the lower or upper bound, you would say that perhaps more it needs to be explored. It needs to be explored. How to interpret few of the important references have been missed. So you can do the search of that topic yourself and find out what is recently published. And you take any article, at the bottom of it in the PubMed, you will find a related article function, and that you will be able to find out. One extra number needed to treat means exactly what, sir? So basically, as I given you the example of the schooling, where you are actually, suppose the rate of bad thing happening, death or impairment is 62% in the control arm and 47% in the arm which is treated with therapeutic hypothermia. Not everybody in the control arm is dying or having a bad outcome. So that is why this word extra. If you do this intervention, as compared to the control group, you would prevent one extra bad thing happening in this group. In a small private setup with no ethical committee, how to conduct a study and get it published? I think if it's a simple case report, case series, cohort, there is no problem, absolutely no problem. But what happens is that eventually, like, if it's a case report, you have to take permission from that patient. or if it is a cohort study, if you don't have your own ethics committee, there are many independent ethics committee, perhaps they will help you with that. If the number of participants in the test group are unequal, how do we conclude the aspect is already? So basically, there are, you are doing a RCT generally, that's why you would do a blocking at every 4 subjects or 2 subjects or 10 subjects, there would be equal number of subjects in the both arm. But sometimes if you are doing the case control studies, you would have more control than the cases, and there are reasons for it, but this is beyond the scope at this time. And post hoc analysis is basically, this is something that you have not planned a priori, you have not written in the protocol, but then after doing the study, you have got an idea, let us explore this. So you would say that this was a post hoc, this was not planned a priori. Shashi, anything else?
No more questions are there in chat box, sir. I just want to ask one question, sir. Sometimes we see some of the studies which have got excessive of statistical jargon, sir.
Yeah.
And it is usually we consider that this study is superior to others. How to deal with such kind of studies, sir?
I think we just stick to simple basic things. Whether they are following the generally recommended norms or not. And suppose they have used something unusual, that means you would start suspecting that there is a problem.
Yes, sir.
That's why they use these other tests. Yeah.
So since there are no more questions, sir, should we conclude the session?
Yes, sir. Thank you so much, Kabra sir and Shashikant sir, for this excellent lecture. And special thanks to Kabra sir for covering it through and through. I think by this lecture, majority of the students and young consultants, they should be able to read and interpret the paper in a better way in near future. Thank you so much, sir, for your time. And we enjoyed, even we extended the time, but we all enjoyed and we were enthralled by your concepts, and you made it so simple, sir. Thank you so much, sir, for joining us.
All the slides were very simple, sir. Everybody would have benefited. All the ranks and files would have been benefited. Thank you so much, sir, for being with us today.
It was a great learning, sir.
Yeah.
Thank you, Akash. I'll share the presentation and you can forward without, and people can use it. There is no problem. There is no copyright. Yeah.
Thank you so much, sir, for your generosity and all the hard work. Thank you, Shashi,
Thank
sir.
you. Thank you. Thank you. Good night.
Thank you.
Bye.
Thank you all the participants for joining.